Oh, yeah. So, hello everybody. We'll start studying cases of endocrine gland pathology. We'll discuss the images and take the basic principles of theory into account. So, the first, this is a CT from a 37-year-old man, and can we understand when you see something black, that means that it is air in it. So, as far as anatomy of the region is concerned, what could this be here? It's a round and it's black. What could this be? What? We're up. Up. No, because the thymus is a solid organ, and it shouldn't be black. Black, it means it has air. So, what is it? The trachea and the lungs, all right? Here are the lungs and the trachea. So, when we have a swelling in the neck, we ask the patient to swallow. If the lesion follows the swallowing movement, that means that it could be related to the thyroid. It is not a lymph node or something below the skin, because these lesions do not follow the movement when you swallow. So, now, the left thyroid lobe, we can see here, because this is the left, since the patient is sitting in front of us, all right? So this is the left thyroid lobe, and we have another important finding from the patient's serum. The calcitonin levels are increased. So when we have a swelling here and we think that something is wrong with the thyroid, we ask for thyroxine, this is T4, trioiodothyronine, this is T3, TSH, and calcitonin. These are the hormones. So here is the CT scan of the patient's neck, and from the family history, we learn that his brother and mother have similar lesions. So what could this be? Taking into account what we have discussed yesterday, because we did the exercise first and now we do the cases. So what could this be? And help us explain why the calcitonin levels are high. What can this be? Which cells produce calcitonin? Which cells? The C cells, the parafollicular cells. So this could be related somehow with a lesion deriving from parafollicular cells. It could be a hyperplasia, which I do not think it is so commonly connected with increased calcitonin levels, but it could be a tumor. So the tumor of the thyroid deriving from parafollicular cells is called, remember, we saw it on our slides yesterday. What is this tumor? It does not have a benign counterpart, it's only malignant, this tumor, which derives from parafollicular cells. It's some sort of carcinoma of the thyroid. Do you remember the histological term which describes this carcinoma deriving from C cells? This is medullary, all right? This is medullary carcinoma, and it is diagnosed with the increase of calcitonin levels in the serum, and there are also some histological characteristics that we will discuss. Since it is a tumor composed of neuroendocrine cells, what else can it cause to the patient? Remember, when we have tumors with neuroendocrine differentiation, that means tumors being composed of neuroendocrine cells. These cells are detected immunohistochemically by synaptophysin, the neuroendocrine markers. chromogranin, CD56, ISN1. These are markers, immunomarkers of neuroendocrine differentiations. Since we have such a tumor, what can it cause to the patient? Because these cells, the neuroendocrine cells, secrete some compounds and they may enter the circulation of the patient. So he might have symptoms away from the site where the neuroendocrine tumor develops, the carcinoma in the present case. So how are these syndromes called? Paraneoplastic. So if a tumor secretes vascular intestinal peptide, the patient will have diarrhea. For example, if the tumor secretes an homologue of ACTH and enters the circulation, this hormone will go to the adrenal cortex and it will produce many more hormones than normal. So if we have an increased secretion of glycocorticosteroids, which come from the second zone of the adrenal gland cortex, the first one is the zone glomerulosus. The other one is the fascicularis, and the reticular. Reticularis is the third one with the androgen secretion. So if we have increased amounts of glycocorticosteroids, cortisol in particular, circulating in the blood, what will the patient develop? The Cushing syndrome, all right? You'll have much fat tissue in the center of the body, a round face, and some very characteristic lines on the skin of the abdomen, and most probably, since the proximal muscles won't function properly, the patient, it will be difficult from him to stand up when he sits in a chair, and he won't stand up very easily. So all these are signs of a paraneoplastic syndrome. So when we have an endocrine clinical syndrome, of course, we look at the gland which secretes the hormone. That would be a primary cause. Then we look at other glands which might interfere with the function of the gland. That means pituitary gland. Then we look at the tumor. If there is a tumor and secretes some substances acting as hormones. And then, of course, the history as far as Cushing syndrome is concerned is important, because perhaps we give the patient corticosteroids to cure an autoimmune disease. So if we have a Cushing syndrome, these are the four thoughts we must have to diagnose the cause of the syndrome. Is it in the adrenal gland? Is it in the pituitary gland? Is it in a tumor somewhere else in the body, like here, in the thyroid? It could be a cause of a paraneoplastic syndrome, these tumors, the medullary carcinomas of the thyroid, because, as we said, they derive from neuroendocrine cells, such as C cells are in the thyroid parenchyma. So, and there is a family history. This is important because such tumor may be part of multiple endocrine neoplasia syndromes, which are of two types. Type 1, if I remember well, has to do with lesions of the pituitary gland. Type 2, we'll see next. Yes?
How can we figure out what hormones a tumor secretes? Can we sequence it to see the...
It's not very easy, because these substances produced by malignant cell are not identical to the molecules of the orthotopically secreted hormone. However, they act like. So I'm not sure that you will find an increase in ACTH, but you'll have the results of an increase. So you think that looks like the action of ACTH. However, I must look for a tumor. It's most common a neuroendocrine tumor, a small cell carcinoma of the lung in most cases, a medullary carcinoma in the thyroid, as in the present case. So, the likely diagnosis is medullary thyroid carcinoma. You see that almost 1/4 of such tumors are familial, and some occur as multiple masses, not only in one place of the gland, but in different places. So the development is multicentric within the thyroid gland. So the gene mutation, RET gene, is probably mutated in such tumor, and it calls for a receptor protein kinase. As far what syndromes should we look for, taking into account that there was a familial history of lesions? In this case, this could be type MEN type 2A, known as Sippel syndrome, where we have thyroid cancer and non-cancerous tumor of the parathyroid glands and adrenal glands, or MEN 2B, where we have the medullary thyroid cancer, as in our case, and non-cancerous tumors of the adrenal gland, and non-cancerous tumors on the lips, on the tongue, and in the digestive tract. So MEN 2 type B does not affect the parathyroid glands. All right? Now look, do you remember these tumors of the thyroid gland, the medullary carcinomas? What do they secrete? And we can see it in the tissue sections. We saw it yesterday. Amyloid. So this is amyloid, and you see the specific histochemical stain, Congo red, which stains the amyloid like this color. You see, yes?
Only the medullary thyroid carcinoma?
Yes, only the medullary produces amyloid among the thyroid carcinomas. Yes, thyroid carcinomas. So let's have a look at the patient's history. It's a middle-aged woman with a neck mass that causes dysphagia. That means she cannot swallow well. Respiratory difficulty due to the compression of the trachea. Remember the CT we saw of the previous patient. And hoarseness when she talks from recurrent laryngeal nerve compression. So all these anatomical molecules can be affected by the development of a tumor of the thyroid. And all we surgeons, when they resect the thyroid gland, they always pay close attention to find where the laryngeal nerve, that section that is called coming back. I'm not so sure how we call it in English. There is, how is it called? Recurrent is called, yes. So they always pay attention because they should not cut the recurrent laryngeal nerve, because then the patient won't be able to speak, all right? So this patient has an increased urine catecholamine levels. So this is something different from the action of calcitonin. When we find increased values of catecholamines, where should we look? The medulla, not the cortex, the medulla of the adrenal gland. Yes, this is one thought, because a tumor might arise in the adrenal gland medulla. This is a pheochromocytoma, and this could cause hypertension, but not a permanent, bless you, not as a, wanted to turn down the air condition, not on a permanent base, hypertension, some sort of attacks of hypertension are caused by a pheochromocytoma. It's just one thought, all right? We'll see. Next, her serum calcium level is increased. You see? Here is the normal limits, and this is 12.8. So when we have hypercalcemia, what do we think? What do we think? Which gland is to be examined? The parathyroid gland. So if we find increased calcium, it might be a lesion of the parathyroids, either primary, such as hyperplasia and adenoma, and very rarely carcinoma of the parathyroids, primary lesions of the parathyroid, or secondary lesions. That means in patients with uremia. That means chronic renal insufficiency. Because when a patient is at an end stage kidney disease, the level of calcium is low in the blood and the level of phosphorus is high. These two electrolytes are always examined together, calcium and phosphorus.
Is
So,
phosphorus the one which binds the calcium?
yes, so that's why we have to look at both of them.
How come one be high and the other below?
If the glomerular filtration rate in the kidney is very low and the kidney does not work properly, then we have the calcium goes in the bones. So the parathyroids become hyperplastic so as to secrete parathormone and restore the levels of calcium. And this causes problems with the bones as well. These are called, they were used, some tumor-like lesions with many osteoclasts, the giant cells absorbing the bone tissue, and these were called osteoclastomas. But generally, if somebody has hypercalcemia, he might have bone pains. So now here we have a complex symptomatology, which we must see which parts, which glands of the endocrine system can participate to justify all these symptoms and findings in the patient's serum. So in the patient, the phosphorus is normal. So we see the amyloid consistent with the diagnosis of medullary carcinoma deriving from parafollicular cells, and this can cause some paraneoplastic syndromes, as we said, Cushing syndrome from cortisol, carcinoid syndrome for increase of serotonin produced by neuroendocrine malignant cells, parathyroid hormone, and hypercalcemia. So hypercalcemia can be a paraneoplastic feature. All right. The tumor may secrete a substance that function as parathormone. Of course, we have to examine the parathyroids first, but if the parathyroids are normal and there are no signs of a parathyroid lesion, hyperplasia, adenoma, carcinoma, then we can presume that this parathormone-like hormone substance comes from the malignant cells of the medullary carcinoma. It's a possibility, all right? Of course, we must check the glands for a primary lesion, but if there is no such lesions, we must think of paraneoplastic syndrome. Now, the elevated urinary catecholamine levels suggest a tumor deriving from the adrenal gland medulla, such as pheochromocytoma, and elevated serum calcium might come from parathyroid hyperplasia, which might be a component of the multiple endocrine neoplasia type 2A. Type 2A is the category in which parathyroid glands participate. Okay?
But for the parathyroid gland, it's
Yes.
considered to be a secondary.
In this case, no, it's a primary. It's of primary origin. If we are talking of Sippel syndrome, of Men 2A syndrome, okay? So we have to make all these considerations. Look at the glands. If the glands are normal, think that it might be something coming from the carcinomatous cells themselves. Okay. Particularly if they are of neuroendocrine origin, such as cells of medullary carcinoma are. No mobile phones allowed. No, don't be afraid, no problem. No mobile phones allowed during the lessons. No, don't be afraid. I'm glad. However, turn it down. Turn it off, please. So here, what is this examination? Which gland is this? And why is it so dark? What do you think? Which gland is this? Which gland do you recognize? Here. Yes. Thyroid. And you remember this test that we discussed yesterday? What is this? Yes, we have a scan. And remember that this iodine is different from the one we give to cure thyroid cancer deriving from follicular cells. So, since the thyroid is so hot, that means it takes the radioactive iodine. What do you understand as far as its function is concerned? This is, how does the thyroid function if you have such a scan? What do you think? Yes, please.
It's normal because the thyroid take up the iodine.
Yes, but it takes too much of it. And it takes it in a diffuse manner. That means everywhere. There is not just an area hyperfunctioning. All the thyroid gland parenchyma works more, functions more. So what can this cause to the patient? Hyperthyroidism. So let's have a look. This is a 37-year-old woman with tachycardia and heat intolerance. These are signs of increased thyroid hormones circulation. She has lost 5 kilos during a period of 4 months, and we have a diffuse thyroid enlargement. It's not the more common form of thyroid hyperplasia, which is the multinodular goiter. This hyperplasia affects homogeneously the whole gland. So it's diffuse hyperplasia. Yes?
How do you diagnose the heat intolerance?
How we diagnose what?
Heat intolerance.
Heat intolerance means that she feels hot, and it's not 40 degrees outside. She feels hot, and the temperature is normal. Heat intolerance. She complains all the time. It's too hot. All right? So this is the scintigraphy. What is the diagnosis? A life-threatening complication having to do with one of the syndromes. If we have primary hyperthyroidism, this is Graves' disease. And what are you afraid, especially in a middle-aged to old man, which organ will be affected by the increased levels of T3 or T4? The first we look is the free T4. Which organ? And it gives a symptom in this patient. The heart, all right? You might have some problems with the heart. And the ocular finding, if this becomes permanent and you won't destroy the hyperfunctioning thyroid cells, what will have with the eyes? We'll see. It's some sort of looking very, the eyes go out, yes, they protrude. We'll see. It in Greek is exophthalmos, all right? So, now, A diffusely increased uptake is typical of Graves' disease. And of course, we have hyperplasia, but without nodules. Not a nodular goiter, a diffuse enlargement of the thyroid gland. And when this is quite acute, this could cause malignant hyperthermia and heart failure. And we have thyroid ophthalmopathy, which might be a permanent complication of hyperthyroidism if we leave this entity untreated. So it might cause permanent damage. Now, we have a 40-year-old woman with tremulousness. That means when she holds a cup of coffee, she may spill the coffee. Palpitations, again, the heart is affected, and congestive heart failure, because the heart must work very severely, and this could cause failure of the heart. Look at the SIRUD, thyroid stimulating hormone, which is quite low. How do you justify this finding in this patient? Why is thyroid stimulating hormone low? Because always we check T3, T4, and TSH. Why is it low? Where is the problem of the disease? Yes? Because of the negative feedback. So there is a primary cause. That means the thyroid gland is the target of the disease. And secondarily, TSH is low. Okay? Due to the negative feedback. And there is a biopsy. Perhaps there was some suspicious area and we took a biopsy. Now, have a look at the biopsy. We see lymphoid aggregations here, lymphoid aggregations, and we see the thyroid follicles. Is there an area, think of what we said in our lab exercise yesterday. Is there an area, the architecture of which looks suspicious for something we saw yesterday? Yes?
I think there is an area here and here.
Yes, these structures look like papillae. So we must pay attention. If they are true papillae, that means they contain a fibrovascular core, and more importantly, to look if the nuclear characteristics of papillary thyroid carcinoma are evident. In Graves' disease, neither of these happen. Neither of these happen. We do not have nuclear features of papillary carcinomas, and these papillary-like projections are devoid of fibrovascular cores. So let's describe the histology. A diffuse papillary hyperplasia with lymphoid aggregates. Lymphoid aggregates are similar because this is an autoimmune inflammation, so the inflammatory exudate consists of lymphocytes. The same is true for Hashimoto's thyroiditis, which is the main cause of hypothyroidism. But here we see the lymphoid infiltrate, the lymphocytic accumulations. We have signs of hyperfunctioning thyroid, and we have a diffuse enlargement. Neither of these is consistent with Hashimoto thyroiditis. So we have increased thyroid hormone production in patients with Graves' disease, an increased level of T4, and a feedback inhibition of TSH production from the pituitary gland. This is the medication which try to inhibit the iodide oxidation and block its addition to the thyroglobulin protein, so that no longer will increased amounts of thyroid hormones are produced. And we have an elevated TSH level with an elevated serum thyroxine level in cases Not so often, but they are described. In cases where we have both thyroxine, free thyroxine increased, and TSH increased as well. Where is the problem in this case? This is not primary hyperthyroidism because TSH is increased. It is not diminished. So in this case, we have a problem in the pituitary gland, most probably a neuroendocrine tumor of the pituitary gland, which secretes increased amounts of thyroid stimulating hormone, of TSH. Now, what is different here? Have a look at this scintigraphy. This area does not uptake iodine, radioactive iodine, so it is thus described as cold. But this is a nodular lesion, so we have a cold nodule. This is not always related to cancer, but it raises suspicions that this nodule might be cancerous, especially if it is single, one only, and if it is solid, like this one. That means it is not cystic. Yes?
I don't understand. What is a normal uptake? What is an image of a normal?
Like the rest of the gland is the normal.
What is the difference of this one with the previous? Why the previous one was more?
You'll ask a doctor having to do with, what are these doctors called? That do the scanning? Radiologists. He'll tell you how do you understand the increased uptake from the normal. When you have a cold area, it's easy because that is white. But as you asked me, if you have a normal thyroid and a hyperfunctioning thyroid, they both look black. However, if it is Graves' disease, the size of the gland is bigger. And this could be a criterion for you to discriminate between these two entities, normal and hyperfunctioning in the context of Graves' disease.
Do you see scans in your normal everyday practice?
Here in the lab? No, we just see tissues, but we must know all this situation, all this data, so as to describe our tissues correctly. This is important clinical and radiological information that we take into account when we take sections from a thyroid lesion, because first of all, we must relate what we see microscopically within the gland with this. So they must tell us where the suspicion nodule is located, and when we will put the thyroid in the right way and see which is the left lobe, which is the right lobe, we'll know where to take many sections. Of course, if it's a nodule, most probably we can see it with our eyes. However, it's not always so. If there are many small lesions, perhaps they can be macroscopically undetectable. So, clinical information is always very helpful for us to do our job. So here we have a cold nodule making less colloid and taking less iodine than the surrounding thyroid tissue. However, most solitary nodules are benign, either cysts or inflammatory lesions, but when a nodule is cold, it is suspicious, not necessarily cancerous, but it is suspicious for cancer. And without the invasion of the capsule or the vasculature, this lesion could be a follicular adenoma, meaning that we have a lesion, a nodule, composed of follicles, thyroid follicles, in which, however, we do not see the nuclear features of papillary carcinoma. If it is fully encapsulated, if it compresses the adjacent thyroid parenchyma, which thus becomes atrophic, or it looks different than the follicles we have in the nodule, and we see no invasion in the capsule and furthermore outside of the capsule with no vascular emboli, that would be consistent with the diagnosis of a benign lesion with follicular differentiation. This is follicular adenoma. In papillary lesions, only malignant lesions are papillary. Follicular lesions can be either benign adenomas or malignant follicular carcinomas. Here is one, quite big. However, it is fully encapsulated, and let's have a look at the clinical information. It causes palpitations, diarrhea, polyphagia, tremulousness, anxiety. These are signs of hyperthyroidism. So such a lesion, such an adenoma, could be toxic. However, its appearance in the scintigraphy will be exactly the opposite as the one we saw. If it is hyperfunctioning, it will be very black because it will take the radioactive iodine. So, and we have borderline hypertension. TSH is low. That means the cause is primary in the gland itself. T4 is normal, however, T3, the triiodothyronine, is increased, very, very increased. You see, 380. And here is this tumor lesion within the thyroid gland parenchyma. So, this is a discrete nodule. It appears red to brown. It could be an adenoma under condition that it does not invade its capsule, which must be throughout the periphery of the nodule. It does not extend into adjacent thyroid tissue, and we have no vascular invasion. And always the nuclear features of papillary carcinoma must be absent. So T3 level is increased, so TSH level is low because the problem is in the thyroid, and this is consistent with a toxic adenoma, which is a rare case of hyperthyroidism. More common cases are Graves' disease, toxic multinodular goiter, it's described as well, a hyperfunctioning thyroid carcinoma, quite rare, I believe. All these are potential causes of hyperthyroidism. Which hormone is firstly influenced by thyroid gland disorders? T4. Here I have some information what is different between the two hormones, thyroxine, which is T4, and triiodothyronine, which is T3. Both have targets in various parts of the body. You can have a look. Now, we have a 46-year-old woman with a left thyroid lesion. Have a look. Why is it dark in its center? What does this mean? Having to do with the nature of the lesion. You see that it is quite well circumscribed and it's dark. So what can this mean?
If it's cystic as fluid.
It could be cystic. Yes, that's right. It could be a cyst. And when we have a cystic lesion, we do not exclude malignancy, but that's not the first thing we think about when we have a cystic lesion. Excellent. So a large non-tender left anterior, a cervical lymph node. Have a look here. When we find lymphadenopathy, that means increased size of nodes, this could be suspicious of cancer. So we have a cystic lesion which is not so typical of cancer, but we have a lymph node increased, which might be metastatic. So what do we need to make a biopsy, of course? We'll take a biopsy. First with a fine needle aspiration, and so we'll see a cytological smear. So a normal TSH, normal thyroxine, and this is the CT, the likely diagnosis. A cystic mass with an associated enlarged lymph node. It could be a metastasis. So we think of the commonest type of cancer, which sometimes it can be cystic. It's not the rule, but sometimes it happens. And here is the incidence of the various types of thyroid carcinomas. Remember that there are 3 carcinomas which retain their differentiation to follicular cells. Papillary carcinoma, follicular carcinoma, and poorly differentiating, though the latter at a diminished degree. It retains this derivation from follicular cells. Medullary carcinoma has nothing to do with follicular cells, so in contrast to the 3 previous ones, it does not express thyroglobulin, because it's of another cell. Its origin is from C cells. And the anaplastic thyroid carcinoma, it could derive from follicular cells, but it no longer shows such differentiation. That's why there is no use to give radioactive iodium therapy. It won't respond. Perhaps it will respond to some degree, nothing really great, to chemotherapy, the anaplastic carcinoma. Here are the genes most commonly involved in papillary carcinomas: RET, NTRK1, BRAF, and RAS. And despite a regional lymph node metastasis, the prognosis remains good. And the 10-year survival rate is excellent, more than 95%. The same does not happen when we have an aggressive subtype of papillary thyroid carcinoma, such as the tall cell variant, when the patient is male, when he is middle-aged, and what is another ominous prognostic factor? If unexpectedly the papillary carcinoma has given a hematogenous metastasis, something that is not common at all. Papillary carcinomas give regional lymph node metastases, which do not affect patients' survival. Here we are. Overlapping nuclei appearing rather empty, with a condensation of chromatin at the periphery and some irregularity in the nuclear membrane, and we also have some grooves. These are the features of papillary thyroid carcinoma. This was a cold right thyroid lobe nodule. No problem with the hormones of the thyroid and TSH, but the microscopic findings are quite characteristic. Empty appearing nuclei. We can also see psammoma bodies, as we said. This tumor is not making thyroid hormone. That's why it appeared in the scintigraph as a cold nodule. However, the remaining thyroid parenchyma works perfectly well. Thus, the levels of the thyroid hormones are not affected. True, yes, it has true papillae, yes. And here are the fibrovascular cores, true papillae. When we have true papillae, we diagnose the classic type of papillary thyroid carcinoma, because that's what the term says, papillary carcinoma. But when we do not have papillae, there are some subtypes of papillary again carcinoma, but without papillae. So papillae are helpful for diagnosing the classic type of papillary thyroid carcinoma, but they are not mandatory to diagnose a papillary carcinoma. It could be of follicular pattern. However, if we see these nuclear features, the diagnosis is papillary thyroid carcinomas. And we have exposure as a predisposing factor to ionizing radiation when the patient is still very young. And there are also some syndromes in which RET gene mutations are involved, and it can be related with medullary carcinoma, which is of a different origin, as we have clarified. But when we have a multiple endocrine neoplasia syndrome, we may have various types of thyroid cancer. So that's all for today. We'll continue the discussion of our cases on Friday. Thank you very much.